right, so I'm going to start over. So we are going to be having new naming come out for the Ehlers-Danlos syndromes. And they're going to be giving a first name to the last name, or a last name to the first name that previously was there. So the first name is the phenotype. So classical EDS is called classical. That would be the first name. And the phenotype is what it looks like. So in classical EDS, it's more stretchy skin. In hypermobile EDS, like a chief feature is hypermobility. Kyphoscoliotic, there tends to be kyphoscoliosis in the spine. But many of these, and they think especially hypermobile type Ehlers-Danlos syndrome, are going to end up having more than one gene associated with them. So currently, classical EDS, in the example here, has the COL5A1 and the COL5A2 type genes. So we're going to see it called cEDS COL5A1 or cEDS COL5A2. And they're expecting that there might be many, many different genes that could make up the hypermobile type, which is the most common type of Ehlers-Danlos syndrome. Okay, next slide. So they did a big study called the Delphi study, and that was a survey that went out to experts in the field. So physicians and allied health providers that are part of the international consortium were all asked these questions. And what they were looking for were, what are the key features that we all think make up EDS or hypermobile spectrum disorder? And what types make up EDS? And then are there key features of hypermobile type EDS? And then certain comorbidities that are most seen with hypermobile EDS? And then what are the key features of hypermobility spectrum disorder and the comorbidities associated with hypermobility spectrum disorder, HSD? Didn't think the line was going to show up. Sorry about that. So expert consensus is kind of what they used for this study, and they used the 75% as the cutoff. They could have chosen 60%, but they chose 75% of people agreeing or strongly agreeing or disagreeing or strongly disagreeing to consider it expert consensus. So they all pretty much agreed that hypermobility was an important characteristic or feature of the Ehlers-Danlos syndromes, and particularly hypermobile EDS. So although you don't have to currently have hypermobility, you can historically have had hypermobility because we know that arthritis can lead to stiffer joints. The lower limb assessment scale, or LLAS, and the upper limb hypermobility assessment tool were tools that physical therapy researchers had come up with 12 points covering most of the major joints in the upper extremity and the lower extremity in order to define hypermobility in other joints that the Beighton doesn't cover. So the Beighton is currently the scale that's being used that involves like pinkies, thumbs, elbows, touching the floor, and hyperextending the knees. But we were finding that a lot of patients had hypermobility in other joints and they were getting missed. And so the doctors have been playing with the LLAS and the OHAT over the last few years and are finding that while a PT might be really efficient and quick at getting that done, and I would argue maybe not, because I've done it and it takes too long for me, that it's not practical for a physician to really be doing all of those joints in their clinic. So they aimed to figure out what are the most important joints they could add to the Beighton that would be helpful. We'll cover that in a little bit. And then they talked about, so from some of the items that are on the 2017 criteria, what's not helpful? And the expert consensus said, hey, marfanoid habitus, or this long arms, long fingers, it doesn't seem to be super relevant. We have plenty of people that don't fit that body shape that are having significant issues. And then mitral valve prolapse, there was less agreement with than they had expected as well. And then the other one was exclusion criteria. So that can be problematic because one of the exclusion criteria is if you had a rheumatological condition like rheumatoid arthritis or lupus, then you couldn't be given the hEDS diagnosis unless you're a rheumatologist that really specializes in this and could say, no, they really have both. And so that they felt was excluding people that had hypermobile Ehlers-Danlos syndrome because you can certainly have both. And so I think that's on the chopping block for things that they want to potentially clarify or get rid of. And then pain was another one that was debatable because plenty of people have lots of pain from osteoarthritis or rheumatoid arthritis. And how do we differentiate the pain that someone with hypermobile Ehlers-Danlos syndrome or hypermobile spectrum disorder has from someone with osteoarthritis or rheumatoid arthritis? And so they weren't really feeling like that was like a criteria that was like super different and stand out from other conditions. So I'm not sure what they're going to end up doing with that criteria. And then pelvic prolapse was kind of a wishy-washy one. Not everybody had that. And the way that it's currently written, you have to have not ever had children and never have been overweight or obese. So, and you have to have had it so young. I think the way they defined it's pretty limiting. So those are the ones that are probably most likely to get chopped. The other study they did was the criteria review study, and they emphasized this is only one study, which was informative, but not enough by itself. And so they took information from that as well, but kind of took it with the Delphi study and some other things. So they looked at basically the differences between those with hypermobile Ehlers-Danlos syndrome, hypermobility spectrum disorders, and control groups. And they asked them lots and lots and lots of questions and then tried to see if there were any distinct groups that stood out from the way they answered the questions. So could we differentiate based on the answers? Someone has hEDS from someone who has HSD and controls. And I might have my helpers mute people as they come in if they are not muted. Thank you.
She made me a...
And I'll just have everyone mute yourself so we don't have background noise. Thank you. So in looking at the criteria study, two clusters emerged, which was really interesting. So they ended up with people that had hEDS and those with HSD, or 75% of those with HSD clearly answered questions similarly. And then there was another group that was controls with 25% of those that had the diagnosis of HSD. And so it was pretty good at pulling out controls. So they're going to have to figure out that 25% of those with the HSD and how do we get a more clean line that gets them into the groups. But there were enough similarities with the HSD and the hEDS that they didn't pull out as two separate groups. They were looking more like one group. And then there were 7 key features that kind of percolated to the top of what they had. So hypermobility, current or past, was one of them. Certain skin signs was another. Certain types of tissue injuries, like the itises, the inflammatory tendinitises and that kind of thing, bursitis, dislocations. I'm not sure how they described that, if that was also subluxations or if it was frank dislocations where the joint was completely not lined up versus a partial not lining up, which would be a subluxation. And then there were certain craniofacial features, so specifically the roof of the mouth being kind of narrow and high, and then teeth, but they didn't say exactly what about the teeth. So that probably dental crowding, since that was the one on the prior criteria. A confirmed family history, since this is genetic, we are seeing that. And then there were comorbidities that surfaced. There are many, many comorbidities, as we know, because every organ system in the body is involved. But the 3 that really surfaced to the top were gastrointestinal symptoms, autonomic nervous system dysfunction, and inflammation. So back to the hypermobility testing, they were finding that either the Beighton or Beighton with other important locations might be helpful. So when they looked at all the range of motion and what was hypermobile in people, there were these 4 areas that predicted in 85% of the time that they would have a positive Beighton also. And we know the Beighton they are hanging on to because it's so old, it's been validated and reliable, and it's easy to recreate. So anything that can correlate with that is going to be a kind of a win. So the joints that they pulled out so that they could make it a quicker screening than doing 12 uppers and 12 lowers were the shoulder, Forearm pronation and supination, which is sort of flipping the forearm over and back. They said the ankle, but they didn't clarify if it was dorsiflexion or inversion and eversion or both. And then they did say big toe, MTP, which is the big joint of the big toe, dorsiflexion, so going up toward the ceiling. For tissue injury, they were including varicose veins, which I thought was interesting because I've certainly seen that, but I've not heard it called out. Strains, like in other words, a muscle pull, and then the tendonitis and osis, and then other itises like bursitis, so some soft tissue inflammation. We talked a little bit about the key comorbidities of the autonomic dysfunction, GI dysfunction, and mast cell activation syndrome and inflammation. They definitely recognize that there can be what we call the pentad of symptoms, where there's upper neck instability as well. But that wasn't as universal, I think, in their hEDS and HSD group. So these were the three that really surfaced. So what they decided to try doing at this point in time is to test a new criteria, like kind of starting point, and see where they go. Because when they did the 2017 criteria, by the time they got to 2018, they already had so much feedback they wanted to redo it. So in this time, they decided, okay, we've got this idea. We're going to play with it for a while and then see if anything surfaces as problematic so that we can clarify it before we publish it, which is great. So I hate to have it delayed, but the plan is that they're going to get all of their data by the time the spring is over in 2026, and then they'll publish that data by December of 2026 in the American Journal of Medical Genetics. And so what they're looking at doing is saying, hey, these 7 key features of HSD and EDS are the hypermobility, skin signs, tissue injuries, dislocations, craniofacial features, family history, and comorbidities. And you can have any 3 of those, and that would make you 90% likely to be in this group of HSD and hEDS. And so if you have any of those 3, you can get this diagnosis. So they're playing with that now, and then they'll get feedback on how that's working for folks. So that's going to significantly simplify the testing. I don't know if anybody's ever looked at the full testing, and there's so many questions. We'll see how they like how many questions they put under each of the 7 key features to be able to be positive for one of them. But my guess is that this is going to significantly make it much, much easier to understand the criteria and to deliver the diagnosis. I think that was a barrier for doctors because it was sort of like you have to have A and B or B and C or A and C, and it got kind of confusing with the different layers of things. So then they went on to talk about other research that's coming and the direction that we're heading in. And so biomarkers and coming up with like an actual test where we could say like, yes, this person has this.
Okay.
Kimberly, I'm going to have you mute your phone because you're popping up. Thank you. So there were 4 groups of kind of future testing that they're looking at. One was to continue ongoing gene testing, so looking at gene structure, the function of the genes, the evolution of how the genes are performing and the environmental effect, and then gene interactions. The other, and we'll go into more detail on these, proteomics, so in other words, how the proteins are interacting in the body, and the extracellular matrix is sort of the environment around the connective tissue, and there's quite a few different proteins in the extracellular matrix that are really important for the process of manufacturing connective tissue and collagen. And so it may not be the collagen, the gene for the manufacture of the collagen that's the problem. It could be the gene that codes for the protein that's important in the process along the way of triggering something to happen to make the collagen, if that makes sense. And so the different proteins can have issues. And then metabolomics, which is metabolites or like small molecules that are made when the body breaks down food, drugs, chemicals, or even in breaking down its own tissue. And there is a little bit of research that's come out in that realm, which is exciting. I'll talk about in a minute. And then epigenetics. So in other words, a gene being turned on or turned off by something. So maybe it's hard to find because the gene's turned off. And so they're looking at some of that stuff. So in the genomics, some of you may have remembered the Norris Labs announcement about the KLK15 gene. And this was the gene that they were very hopeful was going to describe 20% of people with hEDS and HSD. They made mice that had the gene, and all of the mice had mast cell activation and GI issues, and acted as if they had pain. They had pain behaviors. When another lab tried to reproduce their findings, they were not able to do that, unfortunately. And so they're thinking they're going to have to look at maybe a larger group when they're repeating the study. The study that tried to reproduce it just didn't see as big of a difference between the control group and the people with hEDS and HSD. Um, and then I think there was like a 2 to 3% of people in this newer study were found to have signs of connective tissue disorder that had the KLK15, not the 20%. So they're like, we got to do it again. Let's get a bigger group. And then they're thinking, yes, the KLK15 does have a role with connective tissue, so it's a direction that's worth pursuing, but maybe it's not as big as previously thought, and it's not going to be as big of an explanation. So what they're leading toward is that there's like maybe this KLK15 describes a small percent, and then some other gene describes another percent, and another gene, another, and another. There's going to be many, 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 because there's so many different proteins that are involved in the processing of the connective tissue. So proteomics, basically what studies in that direction we're finding is that the HSD and hEDS are very similar. The Norris lab is saying that, hey, we are seeing chronic inflammation markers as something that's present in this group. Um, and then there was a study, Ritelli et al. In 2025. They were seeing complement proteins that are depleted or consumed more. And then this Ritelli found very specifically sized fragments of fibronectin, which is a protein, and then also a very specifically sized collagen fragment that were found in those with HSD and hEDS that was differently sized from what was found in those with osteoarthritis and rheumatoid arthritis. So they also had fragments, but they were a totally different size. And so this could be potentially a biomarker. Unfortunately, they need to replicate the study in larger quantities in order for this to be conclusive and to eventually turn into a lab test. So that's going to be worked on in the future, but so we're not quite there yet, but it's very exciting that this could potentially be a very simple blood test. And if you have a fragment of fibronectin that's size 52, whatever that means, and collagen that's size 30, that's different and specific to hEDS and HSD. The other things that they're thinking they're going to do a little more study on is impaired barrier function and how that's affecting people with these conditions, as well as differences in the remodeling of the extracellular matrix. It seems to be unusual or abnormal compared to controls. So more studies are going to be heading in those directions. So that's exciting. And we're thinking that if we're finding these differences, eventually we could be finding medications that treat these differences. So it may help with some of the symptoms. And then when it comes to epigenetics, they're looking at modification of the DNA via methylation or histones. So methylation is a sort of a chemical process. And there can be upregulation or downregulation of genes. So the gene is sort of turned on, if you will, upregulated or downregulated and kind of switched off. The Sadikovich lab compared hEDS to HSD and fibromyalgia and didn't really find a consistent epigenetic signature. But they're thinking if they could look at more genes and more people, that could be helpful. I would say my argument is that such a high percentage of people with fibromyalgia in other studies have or had hypermobility, that they might be looking at the same people or too similar of a group. They might need to get a different control group. So maybe they want to get their osteoarthritis people or something and do another study. So all this research is happening, and it's very exciting. So the big conclusions of the current research are that hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders are basically on a spectrum, and they're one multisystemic disorder that's sort of on a spectrum. I think they were trending toward, and I think this is sussing out in the research, that hypermobility spectrum disorder is seeming a little less severe on the symptomatology than hypermobile Ehlers-Danlos syndrome. So they are kind of spectrumy. At first they thought that, and then they said no, and now the research is trending toward that direction, but I don't know that they're ready to like state their claim on that just yet, but that seems to be the direction that the research is pointing. But it's all the same, one and the same condition, and what we don't know is, can someone's have HSD and then end up worse than someone with hEDS, and I think probably there's a lot of crossover. They can have similar complications that go beyond what the 2017 criteria describe. And so that really points to like, hey, our criteria, they want the criteria to help direct the care so that doctors don't go, okay, great, I finally figured out your complicated form. Now what? Like, I don't know what to do with you as a patient. And I think that's where the doctors are landing right now. And so they want each of the main of the seven issues that tend to pop up to have sort of a treatment approach attached to it. So like if you have these three, let's institute these treatments. And so they really want the criteria to dictate treatment for patients to kind of help with care. And then again, the hEDS and HSD have similar pathophysiological mechanisms. So they think, if it's epigenetic, it's epigenetic, or if it's the breakdown of tissue, it's the breakdown of tissue for both groups. It's not just one or the other. And that's all I had for kind of updates or the summary of what we're allowed to say at this point in time. So let me stop my screen share and I'll get all you guys up on a big old screen. So if anyone has questions, I'll do my very best to answer. I'm a PT and not a geneticist, and I'm not a biological researcher, but I have read many of these studies, and so I'm happy to do my best to answer any questions. Brenda. You could unmute yourself, Brenda. Yeah, I figured it out. Okay.
There we go. There. Thank you for all of that and attending. That's fantastic. My question, going back several slides, when they're talking about like the diagnostic criteria, did they address at all what the measurements might be to help doctors, as far as like degree angles for hypermobility, or like this, the stretchiness of the skin, it has to be this many, did they talk about that at all?
They did not. So I'm conjecture at best, but they did mention the LS and the LHAT for the range of motion, and those are set angles already made. And so my guess is that they would use the measurements that were for the shoulder from the upper limb hypermobility assessment and the ankle measurements from the lower limb assessment scale. I don't think they are going to deviate from that I know of. So I don't know that if they're doing further studies on those to validate beyond what's already been done for those. So I think that at least for range of motion, that's already set. They were very generic when they said craniofacial features, and they mentioned something about the mouth and the teeth, the roof of the mouth and the teeth, which are so the current criteria says dental crowding and a higher narrow palate. So my guess is they're going to keep those. Yeah, and beyond, and the skin, they said certain skin findings, but they did not go into detail. So I'm going to guess it's some of the ones that they had already on the prior criteria. So like the stretch marks at a young age and without obesity, and the stretchiness of the skin being a certain amount or greater. I didn't get any indication that that was going to change. So I think they're because at this point they're actually using the criteria in their clinics from now until the end of the spring. So I don't know if they have time to change a whole lot beyond that. So I think they're kind of pulling out the pieces that really worked from the prior criteria.
Yeah, I guess maybe it's a problem with education with physicians, whereas one physician says, "Oh no, you're not, hypermobile at all," and or you don't have stretchy skin, and I guess maybe they're just not maybe as aware of what the actual criteria are. So maybe that's where that comes from.
Yeah, and I'm hoping that they can get more detail since, yeah, more detail on the form, so it describes it like right there on the testing form. It was really nice that they came out with a printable one page, but like there was a lot that went behind just the skin stretch, so like, and I think it might have said actually the volar aspect of the middle of the forearm, and I think it might have said the number of centimeters on there, but yeah, it would be nice to have all those details right there on the one piece of paper that we can hand to the doctors. So hopefully they'll do that. Good question. Anybody else? Comments or just comments too? We can pick it apart, start the conversation. Teresa? Were you?
Yeah, hi. I've only been to a couple of meetings and it's been like years ago. So I just want to say hi. My name's Teresa. I have a connective tissue disease, an autoimmune connective tissue disease. So I was one of the people that exclusion criteria made me not get, I don't know. It just seems like
You were gaslit and it took forever to get a diagnosis, perhaps. Alicia here, hello. Welcome. I'm glad you found yourself here and back after a number of years.
thanks.
Yeah. Okay, I'm muting again, darling.
That's,
Welcome.
that's all I had to say.
Yeah, I thought so. Alan Hakim, like he's a rheumatologist, and he said, "Well, I feel really comfortable. I'm a rheumatologist that specializes in hypermobility, so I feel comfortable giving someone both diagnoses. But when we write it as an exclusion criteria, like another rheumatologist is going to go like, I don't know what they were trying to get at. I guess I should just say no." So I think they're wanting to clarify that. So I think that's wonderful because that one seemed ridiculous. We know that the mast cell is very active in the inflammatory conditions that we see, and that is one of the comorbidities that showed up as a biggie. And it's the very same cell that makes an antigen to our own body and makes us autoimmune, right? So if that cell is kind of getting revved up and revved up and revved up, it almost seems like the natural course for it to eventually attack oneself, right? So like that seems ridiculous. So I was really glad to hear that they're really looking at how they can modify that one. Nico.
Yeah, hey. Thank you for that great summary. There's a few people in the chat that are saying thank you, great summary and all that. I was curious if you had mentioned in our sessions about the mast cell stuff and the different things flipping when they got turned on and stuff, and I didn't know if it would be appropriate to bring up any of that now, but every time I hear you say it, I'm trying to remember more and more and more, and I think it's really helpful to learn about, so.
So just to explain a little bit more about what mast cell activation is.
Yeah, and specifically you were talking about how some cells get turned on or flipped over, how I don't remember how you said inverted or whatever, and that's when they become problematic and I can't seem to remember those specific words that you keep mentioning, but also that there's potential new therapies that people are trying that are going really well for some of us and but that's an exciting thing. So
Yeah, exactly. Yeah, so the mast cell is like one of the immune cells, and it actually lives in the connective tissue. And so it's kind of like think of it as a 911. It's like 911's not going to come save you, but like they're going to call in who needs to save you. So there's 1,500 chemicals in the mast cell that the mast cell can call on to help get the process of saving you. So like if you cut your finger, like at first it doesn't hurt that bad, but then all of a sudden about 15 minutes later, 20 minutes like bright red and you can barely touch it. And that's because histamines have dumped out of the mast cell and have created inflammation around there to basically tell you to quit poking it so you can heal it, right? So like it's part of the healing process. It's important to make it hurt so that you know to leave it alone and let it heal. So mast cells are helpful cells. We need them. They also would be they would alert different chemicals to get the process of attacking if like a virus or a bacteria were taking over an area, right? So they're really important for fighting germs. What can happen though in connective tissue disorders is it's like something's not holding something as well as it should. Does that mean it's broken? Should I trigger this healing business where I make it hurt so that you don't touch it? So it can kind of inappropriately be responding. So it can become, so the status is it goes from like, I think of it as a happy cell to like a gun ready to fire, so it goes activated. And in an image, if I can figure out my computer and sharing, I can pull up a quick little video of that's on the internet, where it gets little spikes on it and like all of a sudden these little like chemical packets kind of are popping out of it, right? So it goes from just a happy little chill cell to having these little spiky, I'm ready to spew chemicals, and then it starts spewing and it's supposed to spew certain chemicals for certain problems, not all of the chemicals all of the time, right? And so everybody's mast cell activation can be different because they might be spewing these chemicals or someone else is spewing those chemicals, and then there may be different. So we have medications to like block some of these chemicals, and then we have medications that make the whole cell kind of chill out basically and go back to the happy state where it's not all spiky and ready to go. And so that's kind of how we're currently treating mast cell activation syndrome. And it's like a syndrome whereby it's freaking out about nothing. Like the tissue isn't actually broken. It's maybe not held, or maybe it's like so microscopic we don't need this huge response. Like there's like a little tiny something didn't stick to something else, but we don't need this massive inflammation that it's doing. And in fact, if it gets too mast cell activated, it can slow down the healing process, and it can tax our immune system to where it's so busy kind of getting itself inflamed that it can't fight the actual germ that is coming. So I know myself and a lot of patients complain that like their friends will get a cold and it lasts for 3 days. They get a cold and it lasts for 4 weeks. And maybe the reason is that the mast cells are so overactivated that the immune system's kind of tired and it can't divert resources toward fighting the cold. And so one of the treatments is to like get your system to like have help for antivirals, antibacterials for a while. So you fight colds really well for a while with help. So you can build your energy stores back up, and then the mast cell kind of settles down a little bit, and it's not quite as activated. Because if you're actually sick, it's supposed to activate. So if you have like the connective tissue problem plus you're sick for 4 weeks, like it's really, really activated, and it almost gets like mast cell PTSD, where the more activated it gets, the more activated it gets, the more activated it gets, the more sick you get, the more sick you get, the more activated it gets, and then you're not managing very well and you feel like garbage. And so getting it more stable, getting you better able to fight your colds and germs or keeping you away from them for some period of time can build your energy stores back and get the actual mast cell doing its job in a more appropriate way and not an overactive way. And like, we don't know if this is true for sure or not, but the hope is if we can kind of calm that down, is it possible, question mark, can we prevent autoimmune conditions by keeping the mast cell more under wraps? I don't think we know the answer to that yet. So I am seeing other things pop into the questions in the chat. Let's see if I can read these real quick. There are reactions. We're looking at raising hands also in the bottom of the screen. If you wanted to raise your hand, I see Aaron's got one up. I'll call you in just a minute. There's a little heart. And what always confuses me is I didn't want to heart that. They said something really sad. And I'm like, nope, but if you click on the heart, it'll give you the sad face option. So like there's hands and thumbs up and clapping and some other things underneath the heart react. And then another thing was, I think, there we go. See, we got claps. Yay. Thanks, guys. I think part of your question might have been referring to environmental factors impacting genetics. So turning genes on and off is called epigenetics, is what Stefani said. And then Ray, I'm sorry if I missed this, but will the recording be available to watch afterwards? Yes. So I'm going to try to get it on our YouTube channel, and I will look that up again. I never remember. It's got numbers associated with it. So we can get that in the Facebook group, and then you can email info@oreds.org if you would like that. Oops, I don't think I ever sent my little thing that we were recording. Let me do that. So it'll be info@oreds.org to get the recording if you're not on the Facebook group to receive the email. Okay, Erin, you're up. I'm going to try to
All right, thank
make
you.
a muscle video.
I'm going to leave my camera off because I'm doing my lizard time under my infrared light, and I don't know how it's going to come off. But this is my first time, and I really appreciate this. I'm kind of doing like my own personal study. I've got great doctors, but I've kind of pushed the conversation myself. And one of the things that we've discussed more recently, because I realize I have arthritis now in my neck from trauma, but I also am 99% sure that I have some form of EDS or just some, I don't know. I have been recommended to try prolotherapy or PRP, and just wondering if you can speak to if that's like a bigger conversation that's happening, what your experience has been with that, and what you might share about whether it's been helpful.
Yeah, great question. Gosh, was it at this conference? Very recently, I learned about that prolotherapy. Okay, let me back up. Okay. One thing that we've learned recently is that the fascia in people with inflammation, and particularly the people studied were people with hypermobile spectrum disorder and hEDS, and the inflammation associated with that tend to get more like cross-linking in their fascia. And that cross-linking can lead to improper movement in the tissue and that kind of a thing. The other thing they're seeing is that the presence of this inflammation can convert what was a inert or not movable, not doing anything, just sitting there piece of connective tissue to a contractile tissue. And so like under the microscope, if they put the inflammation, it switched from a fibroblast to a myofibroblast, and was then contractile. And so the fascia contracts, which is really cool in and of itself, that this is an adaptation, probably to splint, embrace, and hold ourselves together a little tighter. But that can become painful is what we're thinking. Also over time, especially if you get more cross-links and things aren't gliding like they need to be gliding. And then with prolotherapy, when they introduced the prolotherapy, the cells immediately switched back to fibroblasts from myofibroblasts. Very cool. And that was what we were kind of wondering is the theory was that prolotherapy caused scar tissue to form, which helped improve and bolster the connective tissue. This recent research is saying, well, quite the contrary. It actually, I mean, maybe it does that too, but it was making the contractions in the tissue immediately release. And so that's kind of the anecdotal finding, that if you talk to doctors that do this, they're like, people feel better immediately. How could they possibly have developed scar tissue already? Like they haven't, basically. And so that's kind of exciting that maybe it's actually helping because it's taking the contraction away.
I appreciate that. I'm a little worried, I'm anxious, I should say, about trying something that I have never tried before, but they seem pretty positive about it.
I've had a number of patients do it and have really good results, sometimes immediate. Sometimes you have to do multiple injections to get enough of a benefit, and it usually lasts for a reasonably long period of time, so like more than a year for most patients. So that would be the problem, or question is it's costly, it's not covered by insurance, and you have to do it multiple times, and it lasts maybe 4 or 5 years, you have to do it again. So It'd be nice if there was a longer term answer, but it can sometimes break the cycle for somebody and get them out of a bad cycle and into a better scenario.
Awesome. Thank you.
Yeah, you're so welcome. Okay, I found the video of the mast cell thing I want to show you guys. Kind of cool. Let's see if I can figure out where my screen share button is. It's under more.
Do you want me to guide you through it, Heather, at all?
Yes, if you can tell me,
Sure,
me
yeah.
where it is, that would be fantastic.
Yeah, it's fine. If you just draw your mouse down to the edge of the bottom of the screen, it's right in the center for me at least.
Thank you. I found it. Thank you.
Yeah.
Okay, let's see. Do I have the right screen? Screen one. I think that's the one. Here we go. Okay. All right, so here's the video. This is a mast cell that's so substance P is like a big, large pain molecule that's being dropped into the petri dish. And look at all the little spiky things that start forming on the mast cell, basically. And then you start seeing like little bubbles coming out. It's like little chemicals are coming out from the mast cell. So that's like an ugly looking mast cell. That's kind of cool. See if I can get it to go back and replay for you.
Can you enlarge the screen on just the
On just this?
video?
Yeah, I think I can. Yeah, thanks. Full screen. There we go. That a little better. Play that again. Just one more time. So the regular kind of circular cell, and then it starts to get little bumps on it as it gets activated with the pain chemical. So that's the catch-22, right? Is that we know that mast cell activation can make histamines, which make us more pain sensitive. Then the more pain you have, the more your mast cells get triggered too. So breaking the cycle is really important for our folks. So
Heather, could I just ask a wee thing?
oops, sorry.
Oh,
Did the share stop?
yes. And
Okay,
I was
great.
just gonna say what I was trying to remember, and you said it during the prolotherapy part was about the mast cells. I thought you said that there was some kind of microfibroblast and fibroblast thing that happened with mast cells as well. And that was the part I was trying to remember. So thank you for saying that.
Yeah, and it's one of the, sorry, I forget which chemical it is that the mast cell makes specifically that they were finding was causing that, the cross-linking of the myofibroblast to switch, or fibroblast to switch to myofibroblast.